right, so one of the questions was, are there any amyloid or tau blocking drugs that can help stop the start of dementia? I think that's how I'm interpreting this question. So as of now, in terms of studies that are looking at preventing the onset of Alzheimer's, there's only three. Two of them are involved in people with genetically confirmed dementia. So they're fairly restrictive into what kind of patients can participate. But the third one is the one we talked about, the A4 study. And this is looking at everyday people with no memory problems, but want to participate. The drug involved is an amyloid antibody. And if subjects are interested, they would come in for screening, do some memory tests, but they also have to get a PET scan, one of the amyloid PET scans we talked about, which is paid for by the trial, and they have to show positive amyloid on the PET scan in order to continue on to the study. All right, so to answer that question shortly, there is only really one clinical trial right now using amyloid antibodies or amyloid drugs to look at whether Alzheimer's can be slowed or prevented. Nothing with tau yet. And that would move on to my second question, which was, who do I call to get into the A4 study? So Emma Hare is our research clinical trials coordinator. She's outside at one of the booths with lots of pamphlets and paperwork, and she would be the right person to talk to about interest in A4, but also any clinical trials. Okay. The next one is, can you comment on the study that Dr. Dale Bredesen published in the Aging Journal claiming to have reversed mild dementia or MCI in 10 or 12 people? So I haven't read through this study by detail, line by line yet, but to my current knowledge, this is what's called a case series. Basically, the investigator will give some sort of treatment to a bunch of patients and just kind of follow them and see how they do, and then go back and look at the results and report them. So this is not one of the standard clinical trials that I mentioned at the beginning of my talk, where you have to pre-specify who you want to look at, what kind of treatment you want to give, for how long, how many people you need, and what kind of outcomes you want to measure, whether it's MRI or memory or function and things like that. So a case series like this paper tends to offer not as strong evidence, especially not as strong statistical evidence, and being a case series, there's no placebo control either. So as of now, I would just say everything's still very early in these type of studies, and I don't have a strong opinion as to whether this is great or very promising or not. The other question is the TV ads about Prevagen. How can they make such claims? Is there any evidence? So I just learned about Prevagen 5 minutes ago, looked it up on my iPhone. But that's an unfortunate state of our kind of nutraceuticals industry right now, is that unfortunately they are not regulated quite as closely as the FDA. So when a company says, this is not a drug, it's just a supplement, it's a vitamin, it's a food, they don't have to go through the same strict evidence-based medicine clinical trials that a drug company has to go through in order to make those claims. So it's kind of a loophole that these nutrition companies are going through. I don't like it, and it's really unfortunate, but it's a Herculean process to correct this kind of regulation. So unfortunately, that's just the state right now. And let's see. Is there any general brain enhancers that might help an FTD patient? For example, something to increase serotonin. So there's not so much a general brain enhancer, but for patients with FTD, antidepressants, some of them are SSRIs, have been shown to have some effect in helping the symptoms. It doesn't change the disease course, it doesn't stop it, but can sometimes help the symptoms from FTD. Of course, before going out and asking for Prozac or whatever, I would highly suggest whoever asked this question to really be evaluated by a neurologist to see if these treatments are necessary. And one other question is, please review how tau can be, and it's down arrows, so I assume they mean how tau can be decreased. So right now there are several ideas in various research labs and companies of how to decrease tau or get rid of tau. Tau antibodies are probably the most advanced and most well-studied, but there are other ways that people are thinking about. Tau is modified sometimes in the brain where other chemical groups like phosphate or acetate can be added to tau, and sometimes modifying these mechanisms may help decrease tau. And there are other strategies, involve something called antisense oligonucleotide. Basically, it's an engineered piece of nucleic acid that can help decrease the levels of tau. But all of these are still very preliminary. The only ones that are really in testing phases right now in humans is the tau antibody, although we do have a very small trial here at UCSF looking at PSP using a drug that can block acetylation of tau, and hopefully that can also decrease tau. All right, and I'll let my colleagues answer some of their questions as well.
So I have one more for you. Do heartburn medications boost the risk of dementia, such as Prilosec?
So that question probably came about from that big study from Germany that was published recently. Joe, if you know more, feel free to add more. But I think they looked at about 3,000 patients, but unfortunately, this study didn't really control for a lot of other risk factors. And these epidemiological studies, it's hard to really say there's any kind of causation. They can only say there's a relationship. So, I wouldn't suggest anyone stopping their PPI right away. Okay.
And I'm not sure who will answer this one, but so this has to do with stem cell research. I read an article about research on brain material created by stem cells at Harvard. Are we doing this at UCSF? Bring your questions.
Oh, I gotta bring my questions.
Yeah.
So the question about stem cells. So the answer is yes, and we're doing a couple of different kinds of projects looking at stem cells. So stem cells are basically the kind of cells that can be manipulated in the lab to create other kinds of cells, which enables researchers to study particular kinds of both either healthy or diseased neurons in a petri dish. And at that point, then you can start really exploring, are there some chemicals that you can do to make the neurons healthier? Is there something about the neurons that make them inclined to get sick? So you can do a lot more things than what you can do when with whole human beings. So basically to get these stem cells, you can you take blood or you can take a little skin biopsy and send those off to the lab. And from these stem cells, you can generate neurons. So some of the kinds of projects that have been done. So there are certain dementia patients who we think have a gene that predisposes toward the dementia. Well, wouldn't it be great to be able to study the neurons who have that genetic mutation in a petri dish to then start to see what sorts of treatments or chemicals or compounds will maintain health in those neurons for a longer period of time. So it's a phenomenal mechanism. Another thing that we're doing, and this is something Yadong Wang at the Gladstone, which is right across the street, is doing, is we know that there's some genetic risk factors for Alzheimer's disease. Well, what if we take people who are fairly old, who have the genetic risk factors, but don't have any signs of Alzheimer's disease? What's protecting those neurons? Well, we want to get pluripotential stem cells from those individuals, put them in a petri dish, turn them into neurons, put them in a petri dish, and figure out what is it that keeps those neurons so healthy. So it's a great mechanism for understanding both risks for disease and things that maintain protection. So hopefully that answers the question. And there are several folks who are doing stem cell research. We're also part of a large tau consortium where we have groups of colleagues who are very focused on understanding these tau-related diseases, several of whom are working quite devotedly with these stem cells. So I'm also supposed to answer a couple of questions about the cognitive aging program, and I think that I can summarize several of the questions that are basically asking, what are the best things we can do to keep our brains healthy? Diets and exercise and social activity and cognitive activity. And here's a long-winded answer to that. So, first of all, how do we measure optimal brain aging? And there are a couple of things that we can do for that. One is that we can actually measure the brain, and we can measure brain volumes, or we can measure the white matter in our brains. And the white matter in our brains are really important for maintaining the connections between neurons. So the white matter really allows us to more easily process things quickly and make lots of different connections. And then you can measure cognition, and we usually focus on things like memory. How well can we take new information and hold on to it? We want to look at how quickly we can process information, and we want to look at things like how well we can multitask or organize things. And what we've noticed so far is that you can pretty much consistently measure changes in brain volume. So as time goes on, certain brain regions get smaller, and there's less of this sort of white matter that enables us to do all these connections. We actually have a slightly more challenging time in this particular group in measuring cognitive decline, in part because those of you who are participating in our aging research are just so incredibly smart and are already doing all the things you need to do to keep your cognition healthy. So while there's a lot of variability in how people's memory changes, on average, the group doesn't show declines in memory. There are some folks who do, there's some folks who don't. What we really want to understand is, for those who really show improvements, what is it about their lifestyle that maintains their memory? And probably the cognitive ability that's most vulnerable to change, even in our typical healthy cohort here, is processing speed. Right? So if we think of brain structure as a really target, we want to keep that as robust as possible, and things like processing speed, keeping that as fast as possible. What are some of the things that help? Well, the next layer to consider is, well, what are some of the biological pathways that our lifestyle influences? So we know that inflammation is bad for brain health. We know that there are some proteins that are not the kind you eat, but the kind that are circulating in our bodies. Some are bad for our brain, some are good for our brain. Vascular changes. We don't want to have changes to, negative changes to our cerebrovascular supply. So anything that we can do to maintain optimal blood flow and the health of our capillaries and arteries that are feeding our brain is going to be really, really important. And then there's metabolic pathways like glucose metabolism that have a real impact on how well our brains function. So now we can start thinking about some of the lifestyle variables and which ones that we know the most about and which ones we're really not so sure about. So people have asked about diet. And to be honest with you, I don't think that there are a lot of super definitive ideas about what kinds of diets we should have, other than anything that's good for your heart is going to be good for your brain. We're pretty clear. I think it's becoming increasingly clear that high sugar diets disrupt insulin resistance and is bad not only for your heart, but also for your brain. So I think that high sugar diets aren't good. The field is always going back and forth on fat, right? And, some people now think that it's okay to have more unsaturated fats, whereas saturated fats are still kind of bad. Clearly, a high saturated fat diet that's clogging your arteries is neither good for your heart nor your brain. So I think we're pretty clear on that. In terms of supplements, there's really not a lot of great support. If you have a balanced diet, it's not really, the support for supplements is not all that convincing. Now, there are some very big trials out there. There's a huge vitamin D trial that will hopefully yield some pretty interesting results. It's been going on for about 5 years, but they haven't broken the blind, so we don't know who's on vitamin D supplements and the omega-3 fatty acids and who's not. And then we're planning a sort of a multi-site study here to look at vitamin D along with a couple of other University of California. So there's exercise, physical exercise. So there's no question that physical exercise is good for your heart. If it's good for your heart, it's good for your brain. It's also associated with an increase in one of these proteins that's actually good for your brain. So there's a growth factor that your cells create more of called brain-derived neurotrophic factor. And the more that you have, the more able your brain is to create new neurons. So physical exercise has a couple of different routes toward maximizing brain health. Not only direct effect on the brain and good effects for your heart, but it might lower inflammation. And people sleep better. And sleep is one of those things that has a real significant impact on not brain function, which is kind of obvious. If you're sleepy, you don't think as well. But we're also realizing that chronic poor sleep may actually increase your brain's tendency to form some of these amyloid plaques. So good sleep, but we're pretty sure about physical exercise. We're pretty sure about healthy diets, low sugar. We're the most confident about those. And we need to learn a little bit more about the cognitive exercises and social connectivity. There's epidemiological evidence to support all those. And I think the next phase is to start doing some randomized clinical trials.
So there's a question about, is there any specificity about prevention for, say, for example, amyloid versus tau, anything like that? Are we able to differentiate at this point in terms of prevention?
I don't think so, but maybe there's some folks on the panel who have more insight into that.
Which probably leads to Gil answering some questions. So one might say that a way to prevent chronic traumatic encephalopathy is to not hit your head. I don't want to get in trouble, but, think about playing football, think about playing soccer. But he may have some things to say about that. We have some other questions for Gil as well.
Where are my questions? Oh, there.
Do you want me to?
I'll just so there is some specificity for risk factors. For example, poor sleep has been specifically related to an increased buildup of the amyloid plaques, the amyloid protein. We know that there are exposures to pesticides or certain heavy metals like manganese that are specifically associated with Parkinson's disease, for example. So there are some specific risk factors. I don't think we're at the point yet where we can talk about some of these lifestyle things in terms of diet, exercise, cognitive activity, and suggest that they are helping protect the brain against one bad protein but not another. So that's kind of the short answer. All right, a few people were interested in football and PET scans. So, but actually, the first question I'll field has to do with a recent study that got quite a bit of press. A recent article says dementia incidence is decreasing, but we have heard here that more patients are expected. Can you explain the apparent discrepancy? So this is a really interesting point. There was a paper that was published in the Journal of the American Medical Association just a few weeks ago that showed a decreasing incidence, so fewer new cases of dementia. And actually, this study is not alone. There's now a body of literature looking at different populations that suggests that the rates of new cases of dementia might in fact be decreasing. And this is really interesting. So what's changed really over our lifespan that might explain some of this? One thing is people are more educated than ever. And so we know that more education seems to protect people against developing cognitive impairment with aging. A more educated population might have less dementia. From a medical point of view, the major success story in the past 30 years has been cardiovascular health. No doubt we're screening better for risk factors for heart disease. we are treating them better, and we are really making an impact in cardiovascular health. And as Joel said, good for the heart, good for the brain. So it may be that some of the lower rates of new cases of dementia might be related to people living healthier and having better screening and treatment for their cardiac risk factors. So these are some of the potential explanations. It's important, though, to distinguish between, and this is kind of getting into epidemiology, distinguish between incidence and prevalence. These are two different terms. Incidence means the number of new cases. Prevalence means the overall number of cases in a population. And so even if the rates of new cases of dementia might be decreasing, for example, in 75-year-olds, people are living longer than ever. And so a 75-year-old today has a longer expected lifespan. And so it may be actually that even if there are fewer new cases in a population, with an aging population and people living longer, the overall number of cases increases nevertheless. And so there's no doubt that cognitive health is a major public health issue facing our country, facing the world. We are hopeful about some of these data that suggest that maybe better education, better lifestyle, better treatment of cardiovascular risk factors might be having an impact on this, but there's a lot of work still to do, no question. Okay, please say a little bit about the radiation exposure associated with the different imaging techniques. So really, at the MAC, we have two major types of imaging that we do. The most frequent imaging that we do is MRI scans. How many people here have had an MRI? Is probably everyone, pretty much. If you don't have metal in your body, we'll scan you if you're willing. MRI doesn't involve any exposure to radiation. The MRI is a magnet, and the tissue images that we get are related to magnetic fields. So there is no actual ionizing radiation exposure associated with MRI scans. The second technique that we're using increasingly are PET scans. PET scans do involve exposure to radiation. The way a PET scan works, and I didn't have time to get into this, is we actually take a small molecule that's labeled with a radioactive isotope. We inject a tiny dose, a nanomolar dose, for those of you who had chemistry, into the body, and then that small molecule binds to a target in the brain, say amyloid or tau or something else, and we can actually detect, with decay of that radiation, there are photons that are released, and those photons can be detected by PET scanners. And so what we are using to image amyloid tau in the brain is radiation. And what is the exposure? It's the amount of radiation exposure associated with the typical PET scan that we do at the MAC. Let me try to put it in sort of some lay terms. So it's equivalent, roughly, to the amount of radiation that we get just walking around in the world over 2 or 3 years. So for that one scan is equivalent to just background radiation exposure over about 2 to 3 years. To put it in the setting of a medical procedure, it's similar to the kind of radiation that you get if you have a CAT scan of your chest. So it's well within the radiation exposure that's considered safe for research purposes or for medical use. But that said, radiation isn't good for people. We know that the more radiation you're exposed to over your lifetime, the higher the risk of cancer. And so we're not so much worried about the dose of radiation that you get from one scan or even multiple scans, but it's by participating in research and exposing your body to these scans, you are increasing your cumulative radiation exposure by some amount. And the added risk of getting cancer because you had a PET scan is so small we can't put a number on it. We can't say you're increasing your risk in your life by 1% or 0.1%, but it is more than 0. And so people just need to be informed about that when making decisions about whether they want to participate in these scans. Everything we do is approved by an institutional review board. All the human research that we do that goes over risks and benefits. And in fact, the PET scans that we do are reviewed either by nuclear medicine at UCSF or by the Lawrence Berkeley Laboratory Review Board, which is very sensitive to this issue of radiation. And so I think there are very conservative people thinking about the protocols that we're doing, who are very informed about radiation risk, making determinations about whether, the risk, the benefit to society really outweighs the risk to the individual subject. Okay, let's see if I'll even get to football. Just pull me off the stage when you're ready. Disclosing PET results. We disclose results of amyloid PET scans in people who have a diagnosis of either mild cognitive impairment or dementia. We typically do not tell people who are cognitively normal their amyloid PET results because we don't yet really know what that means in terms of risk of getting Alzheimer's disease. The one exception to that is the A4 study, where part of the consent process is people who are normal have to agree that they want to know their amyloid status. You will be told if you participate in the study whether the scan whether it showed it elevated amyloid or not. And then people who are positive for amyloid, as Richard discussed, are randomized to get treatment or placebo. So that's the one exception. But in general, we only disclose amyloid PET results to people who have mild cognitive impairment or dementia, and that's within the FDA recommendations. Tau PET, which we have been doing now for 2.5 years, imaging tau tangles in football players or Alzheimer's disease or PSP, is a really new technology. We're very excited about it, but we don't yet feel like it's validated enough, that we know that the scan is reliable enough to provide that information to patients. And so our IRB, our Human Research Committee, has determined that that scan is not validated enough for us to disclose the results to patients. At some point, I expect that will change, but it's not the case at the moment. So if you're doing tau PET scans as part of our research, it says on the consent form, and we go over this, we will not be able to give you the results. Another question about amyloid PET had to do with whether the scan is accessible in the clinic, whether someone can actually go to their doctor and ask for an amyloid PET scan. So the FDA has approved this technology for clinical use since 2012, but Medicare and other private insurers don't reimburse the cost of the scan. So the out-of-pocket expense associated with getting an amyloid PET scan is around $5,000 to $6,000. So very few people have gone ahead and gotten the scan if they had to pay for it out of pocket. The IDEAS study, which Howie discussed, is a mechanism by which patients will have access to the scan, again, if they have mild cognitive impairment or dementia, not people who are cognitively normal, but people who have been diagnosed with cognitive impairment. When the doctor feels like the cause of impairment is uncertain, and knowing the amyloid PET result would help inform the management of the patient, people will be eligible to participate in this large national study, the IDEAS study, where Medicare will actually cover the amyloid PET scan. Now, the copay associated with that is whatever your Medicare copay otherwise is. So we expect that most people have supplemental Medicare, won't actually have to have any copay. But if you have just basic Medicare, it's a 20% copay. It's not for that full $5,000 or $6,000 at UCSF, it's a subset of that. So we think the copay in the worst case at UCSF would be in the $250, $300 range. But again, we think most people will actually, based on their Medicare coverage, won't have any copay at all. So Medicare is paying for the scans to see if they have clinical utility, if they really change what doctors do, how they take care of patients, and whether it improves outcomes in patients. So that's a big win with Medicare. They've committed $80 million to this study. And this is really an unprecedented level of commitment for Medicare to study new diagnostic tests in Alzheimer's disease. Okay, is the evidence on CTE sufficiently compelling that UC Berkeley should close down its football team tomorrow? I'm a Stanford alum, so I'll say absolutely. No, to be serious, there are views in the field that say that no one should play football, that everyone who plays football not only will get CTE, but already has CTE. I think this is an extreme exaggeration of the scientific evidence, to be honest with you. I think the evidence clearly shows that people who have repeated traumatic brain injury, that is a significant risk factor for CTE and for other disorders. But I personally don't think the evidence suggests that everyone who played professional football has CTE or is going to get CTE. So let me make an analogy that I think is appropriate, which is the analogy to smoking and lung cancer. I think that we know that smoking is a risk factor for lung cancer, but we can't claim that everyone who smokes has lung cancer or is going to get lung cancer. And in fact, smoking is a risk factor for many other things: heart disease, peripheral vascular disease, etc., stroke. And in fact, we know some people smoke, their whole life and live to be 100 and, have a healthy life. So it's a significant risk factor. I think protecting your brain is a good idea, but I don't think there is evidence at the moment to suggest that football should be banned, that, people should close down their teams. It may get there, to be honest with you, but the science isn't there at the moment to justify that. I think what we are able to say now is that people who decide to play football are going to be much more informed, especially at the professional level. These are adults, entering this world. They're going to be more informed about the risks. And I'll just quote one of the players who I saw who said, we saw the old guys in the league. We knew, that this was going to take a toll on us in our 60s and 70s. I didn't expect that I'd be having these symptoms in my 40s or 50s, though. And so there is, I think, more and more information about this. Let's see. I think I answered my questions. I think so. Do you have more? Oh, okay. There were a couple others. So one question asked about steroid use, anabolic steroid use, and whether that is a risk factor for CTE. I think it may be. We don't really know yet, again, what modifies the risk, so why some people play football and don't get any problems, other people get dementia. One of the suspects, I think, are performance-enhancing drugs, and this is something that needs to be studied. The big problem with the science in this field is that the only time to diagnose CTE was after death with autopsy. And now with the evolution of some of these new imaging techniques that are going to allow us to detect the tau protein during life, we're going to be able to do much larger studies that are going to be able to address these questions much more quickly than doing studies based on brain tissue, which by definition are small, and also suffer from something we call referral bias, which is that people are more likely to donate their brain if they're suffering from neurologic symptoms or if their loved ones suffered from neurologic symptoms. So we might be getting this inflated sense of how common this disease is because people who suffered from neurologic symptoms are donating their brains at higher rates. And in fact, some of you may have heard NFL players committing suicide, shooting themselves in the chest and leaving a suicide note saying, please donate my brain for research. This is now code in the NFL when someone shoots themselves in the chest for wanting to contribute. But these are people who suffered from severe symptoms, depression, cognitive symptoms, other psychiatric symptoms. So we're going to be able to do much better studies if we can detect the changes associated with CTE with imaging, for example, or blood samples or CSF samples. And then there was a question about CTE from the IEDs, the improvised explosive devices. May they explain the high suicide rates with returning military veterans? It's a really interesting question. Very high rates of PTSD, depression, substance abuse in returning veterans from the recent wars. It's a complicated question. How much of the PTSD or depression is actually related to tau protein or white matter injury or other changes in the brain? How much is a reaction to what they have seen psychologically, exposure to substances in the military? It's a complicated question, but a really important one. My personal guess is that, yes, I think traumatic brain injury, exposure to blasts, may at least be in part responsible for the high rates of depression and suicide in these guys. All right.
Serggio has some questions about
I have that little, this one.
that one.
Yep. I have two questions. Couldn't the MAC create a program that could be brought into Spanish immersion public schools for kids that they could then bring home to their grandparents and parents to start the conversation? I think this is a visionary question. I love it. It's something that I've thought, and it's something that I would love to do. Extend education to younger generations precisely for that purpose. That, you know, I have a daughter who's 6 years old, and she's already coming home and asking me, "Hey, Dad, why are we eating this?" You know, and raising these questions based on things that she learns in school. So I think that's a great mechanism through which we can change our views of the brain. And again, brain literacy, I think that's very important. The other question, I'm not sure I may be revealing a lack of understanding, but let me read it. Where is it? How can you increase diversity when outcome studies are double-blind and a pre-selected cohort will defeat the purpose of double-blind studies? I think there's an issue here that randomized controlled double-blind studies, the double-blind piece comes in that the person receiving the intervention and the person doing the intervention are blind to what's going on. But you're not blinded to the ethnicity and the language of the participant. And in fact, that's what we want. We want a cohort that is very diverse, and we want scientists to know that it's diverse. Unless your outcome is diversity, which I can't see a study right now. And maybe there is a method where you can do that, but
I mean, I think the one thing to add is ideally you'd want to control for that. So if you had a study that had diversity, you'd want to make sure that you track and represent that diversity and can quantify it, and even try to analyze things like, did one group perform differently or respond differently to the other?
and that's how we learn
Right.
about.
In the planning stages that Richard talked about, you'd have to decide how many people of each group would I need to find that, and you may have to double or triple your sample size to be able to answer that question.
Mhm.
But we can't, right? We can't add a sizable group that's as large as our typical groups that have this second or third or fourth ethnic identity that we need.
Thank you.
And Howie has some questions of his own that he has, but wanted to address the hereditary nature of dementia. You know, if you have a diagnosis, you have a sibling or a family member, what does that do to that person's risk? And then you go ahead.
It's becoming a more and more complicated question, this question of heredity. So I'll try to summarize what I think is a long discussion briefly. There are multiple ways in which we can inherit a risk for dementia or degenerative disease. And the one people think about the most is something that we call autosomal dominant, which means you inherit an abnormality in one of the chromosomes from one of your parents, and there's something so problematic with that chromosome that at some point you will get that illness. In neurodegenerative disease, the most famous disease like that is Huntington's disease, which Woody Guthrie had and Arlo doesn't apparently. So the only way people get Huntington's disease is if they inherit it from their parent. Most of the diseases that we talk about, they're not inherited that way. The major risk for developing Parkinson's, Alzheimer's, frontotemporal dementia is aging, unfortunately. And it varies disease to disease. So frontotemporal degeneration, for some reason, we're a little bit more vulnerable when we're a bit younger, in our 40s or 50s or 60s, as opposed to Alzheimer's, when the typical time to be vulnerable is closer to 60s, 70s, the 80s, in that range. But they're all diseases of aging, and those are by far the biggest risks. For each disease, Alzheimer's, frontotemporal degeneration, any of the other ones, there's a small group of people who have some abnormality in one of their chromosomes that puts them at risk in the same way that Huntington's patients are at risk for Huntington's disease. But it's not the majority. In Alzheimer's, it's probably 2%, 1%, very small proportion. In frontotemporal dementia, we think it might be 20 to 30 max%, bigger than Alzheimer's as a proportion, and in other diseases it varies. So in most people, especially if the belief is that their parent or a sibling has Alzheimer's, the likelihood that they're at very high risk, meaning 50-50, because if I got the same thing my sister got from my parent, then I'm going to get this disease. It's really a very small proportion of Alzheimer's patients that have that kind of risk. On the other hand, we have lots of other chromosomes, and those chromosomes have much smaller effects on our health. Some are helpful, some are not so helpful. We get a different mixture, from each of our parents, and then they mix up in us, and then they actually distribute themselves through our cells, as we develop and grow in slightly different ways. And all of that is much more complicated. And a lot of what you hear about of genetics and heredity is trying to understand that much more complex environment of all the different genes that we inherited, what balance and combination we have of all of them, and what does that mean? And now we have these things you may have heard about called whole genome sequencing or whole exome sequencing, which means at a reasonable cost, we can characterize everybody, all of their DNA. So it gives us the tools to potentially answer those kinds of questions, but everybody has a huge data set in them now, many, many, many observations. And statistically, you can imagine if you have many times many and you're trying to figure out what 1 or 2 or 3 little effects are, it's very hard to find them. So it actually, I'll now answer another question, because somebody said, well, you mentioned a bunch of studies, some of which seem to overlap, and they asked about sharing. Do the studies share across the different studies? And actually, the answer is absolutely yes. At the Memory and Aging Center, we have sort of a core central set of resources, a central database, central servers. They're all password protected. Only Memory and Aging Center investigators can get to them. But we all know about them. So if somebody's been in one of Dr. Rabinovici's studies or Dr. Kramer's studies, I know about those studies, and vice versa. If they've been in one of his studies and I think I'd like to add a few tests, he lets me invite them to do those extra tests, and vice versa. Beyond that, we share all these data with the world at large. So because we're a federal Alzheimer's center, we upload all our data every month to another password-protected, limited access place that the National Alzheimer's Coordinating Center holds. And they have data on probably about 40, 50,000 people now who have participated through centers like ours. And there are even larger databases. Once it gets beyond us, it never goes with anything that we call PHI, which is personal health information. So somebody going to those data can never figure out which individual contributed it by name or anything like that. But it is available to all these people. And it's been used many, many times for these kinds of questions that require a lot of people to answer to participate. So that's the genetic story. Is there a dementia that presents as loss of language? I'm going to do like quick answers. Is there a dementia that presents as loss of language skills? Yes, it's called primary progressive aphasia. But having some word finding trouble as you get older is not primary progressive aphasia. It is one of the 2 most common things we hear, in addition to, I forgot what I was going to do when I went into the room. So if you have those 2 things, those are not red flags for dementia. But if you're having more significant problems with communication, that's another way that neurodegenerative diseases present. Is UCSF working with Kaiser Permanente? Yes, in several ways. Our center, the MAC, has an ongoing collaboration with Kaiser where we ask them if they would refer cases to us that they find particularly challenging, but also that would be interested in our research. I'm pretty sure some of you came to us through that program. And it's been growing. We're seeing people from more and more Kaisers around the Bay Area who are learning about this. The other way that UCSF works with Kaiser is at a kind of institutional level. So the study that somebody asked about, did you talk about it? Anybody talk about you didn't talk about the different incidences of dementia studies you talked about. There was a study recently that showed, using Kaiser data, that different ethnic groups seem to have different prevalences or likelihoods of having dementia. And that study was a collaborative effort between researchers who are experts at epidemiology and population research and the Kaiser folks who have all those data and also are interested in those questions. Other websites or websites relevant to this presentation, all of these websites, as I said, will go on our website, and then you can click, meaning the videos will go on our YouTube channel, which you can find through our website. I think there are lots of other good resources out in the world. Probably the easiest one I can point to is the Alzheimer's Association. They have lots of material on updates on clinical trials and what's going on and different kinds of research. They refer people. I don't know, would anybody say there's another definite we should, for frontotemporal degeneration, there's the Association for Frontotemporal Degenerations. They try to serve that same role that the Alzheimer's Association.
There's an organization sometimes for each diagnosis, there's an organization called Cure PSP that also has a lot of information, not just about PSP, but also cortical basal degeneration and a couple of other diseases. There's also a Lewy body disease organization that has a very good website. I think they're all linked on our website, but you can also, and as far as primary progressive aphasia, there is a very nice website at Northwestern University, and then there's some other online forums. So once you kind of branch out, you'll find a lot of these resources.
Right. And we try to keep abreast of them, and if you know of resources that you think we might want to link to, you can tell us that. Is there, what's the relationship between UCSF and the Institute on Aging? I think it's growing. So we've had relationships with them over time. I think because they've come from a geriatric perspective, which is much broader than I think what our perspective started out as. We were very focused on diagnosis from a neurology perspective. We didn't have so much overlap with their efforts, but I think as we're branching out and learning about care and thinking more about our problems in the context of aging, we're working with them more. In fact, some of our recent training programs that we've asked for funding to renew, they focus really a lot more on interaction with geriatrics. The geriatricians are a big part of this global brain health initiative. So I think that relationship is growing. Is there a specific test for familial frontotemporal degeneration for early detection? So the answer is no, we don't know that yet, and that's why we're doing this study. We're focusing a lot on every kind of symptom we can imagine that we think might be relevant, psychiatric symptoms, cognitive changes. We're using some very sensitive tests of cognitive ability that we think might be more sensitive, and we're following people over time so that we can add on the idea that, well, it's hard to know if you're a little bit low on this test, whether that's just you or whether it might mean something. But if it means something, then the chances are that you'll change more than average over the next year. So by doing these kinds of longitudinal studies, we can be more sensitive potentially. But if we knew the answer, of course, we wouldn't be doing the study. What about specific tests for the presence of amyloid? I think Gil talked about that a lot. And the A4 study and other studies are focusing on that. This one's up. We hear it a lot, even though it's a kind of a very specific question. What's the difference between delirium and delusions? So delirium really is a medical condition that describes the fact that you are altering your cognitive ability in a very labile way, and that it's quite different now from how you were just a few hours ago or a few days ago, and come and go. It tends to be a disorder that's caused by illnesses that are affecting your brain right now, like an infection or an intoxication, like with alcohol. Being intoxicated with alcohol is a form of delirium, lots of other drugs. So that's delirium. And in that sense, we don't think of it as a direct symptom of neurodegenerative disease. Neurodegenerative diseases are diseases that slowly develop over time, and everybody's awake, alert, interactive, and yet the memory becomes a problem or other things. On the other hand, people who have some problem with the brain are much more vulnerable to alcohol, toxins, medication side effects. So somebody with a degenerative disease can get a delirium on top of that because something else has happened. And in fact, it's one of our first things we always recommend is if a family says everything was fine until a few weeks ago or less, and all of a sudden, much more forgetful and really sleepy and like hardly able to communicate, our first reaction is not, oh, this degenerative disease has gotten worse, but rather there's something else going on. And it could be as simple as a urinary tract infection or a change in medications, depending on that. So that's delirium. Delusions is a symptom that describes beliefs about things happening that are not realistic and probably not true. That somebody's stealing, that aliens are visiting, that you are somebody who you're not, and that people have a special relationship to you. These are all different kinds of delusions, and they are symptoms of psychiatric illnesses like schizophrenia and bipolar to a degree, and many others can be delusional. It's really a core feature of schizophrenia. And they're also symptoms of the degenerative diseases we see, including Lewy body dementia, sometimes Alzheimer's disease, frontotemporal degeneration. And so it's a very important area of study for us is when somebody's getting a delusional disorder late in life, and maybe people haven't recognized that they're actually getting a degenerative disease, how would we recognize that? And how would we help community doctors think about them not just as psychiatric patients, which is important enough, but also that they might have a different biology going on that is more in our category. So that's my miscellany of questions. Anything?
There was one I handed you. I think it had to do with how are we training physicians or helping community physicians diagnose frontotemporal dementia, or are we doing that?
Well, I think we are. So I'll answer the last part first. I think we're helping. I think now we're getting lots of referrals from Kaiser, for instance, of frontotemporal degeneration that they would have all been called Alzheimer's disease in the past. In fact, sometimes I think we're now reversing their diagnosis. So they say it's frontotemporal degeneration, and we say, no, actually, in this case, it might be Alzheimer's. So the fact that they're recognizing it and sending it to us and asking us about it rather than us having to bring it up as a possibility, I think represents a great advancement. And it's happening because we send letters back to them and we have conferences with them, talking to them about their own cases. Dr. Kramer and I in particular, and Robin, do that regularly. Of course, we help community physicians by publishing and trying to simplify the approach and make the criteria as easy as possible to recognize. We help by doing lots of talks in various contexts to sort of bring that into a discussion rather than just something someone reads. And I think things like this Quest Diagnostics business that I mentioned, where we're trying to work out with them almost a web-based algorithm that a physician can use to try to say, well, when I heard this symptom, I thought of this, but it says you should have thought of these other 3 things. And if you did, you can add these 3 additional tests and it might help. That's the nature of it. So, and that does multiple things. It brings to mind things that maybe they didn't think of, and it gives them additional tools to suss that out and to decide whether in fact that's a problem. So we're really trying to do it on multiple fronts to expand knowledge, and I think it's working. Dr. Miller would have, he'd often show papers about frontotemporal dementia. The number of papers of this disorder discussing it have, risen, by orders of magnitude over the last few years because the community of frontotemporal degeneration researchers have, been productive and shown people what this is and how to recognize it. Would you add anything to that, guys? So we're doing a lot, and we're not done yet, though. We know that.
Lisa,
Once.
final comment?
All right. Final comments from Lisa? You gonna make some final comments? Any last question? Joel, did you wanna? Okay, Joel had one last question. He's gonna be the swan song question and answer. And I'll say thank you. I won't come back on. Thank you so much for coming, and don't forget to turn in your evaluations.
This is such a good question. So concussion studies examine repetitive physical impact on the brain. Has the same thing been done for chemical impact? Alcohol, prescription drugs, illegal drugs. So 99.9% of the research on all of these are acute effects, and very little has basically studied, how about all that dope you smoked in college? Is that going to affect how your brain is going to change as you get older? There are a couple of things that we're probably more confident about, so that it's pretty clear that heavy use of amphetamines and cocaine increases the amount of cerebrovascular injury. Again, we don't know what happens to someone who's had that impact in their 20s and 30s and how they're going to look in their late 70s and 80s. The other thing that is abundantly clear is that excessive use of alcohol is definitely damaging to the brain and to cognition. And we've participated in some of the research that have shown that in chronic alcoholics who have been clean and sober for 3 months, 4 months, 6 months, a year, continue to have smaller brain structures and some residual cognitive symptoms. We still have not figured out, though, that if someone had substance abuse issues in their 20s, 30s, or 40s, but are now clean and sober, whether this has any impact on how their brains age in their 70s or 80s. So, that being said, we know that, again, in terms of acute effects, that the kinds of chemicals we put in our bodies, including prescription drugs, can definitely impact cognition. And I think one of the more common sources of delirium that Howie was talking about is either over-medication or the wrong mix of medications that our doctors are prescribing. So, definitely a really important, these toxins are definitely, and drugs and chemicals are an important player in sort of day-to-day cognition. All right, so, but I won't even mention the possible positive effects of red wine on brain function, because it's too early in the day for you to get started on red wine. And Lisa's going to wrap it up.
I just wanted to thank you all for coming. And so there'll be a couple people still, like the coordinator from the clinical trials team and the care ecosystem, and someone from the Alzheimer's Association is still sort of sitting outside and will be. So if you have any last if you want to stop by those tables on your way out, that's great. But thank you very much for coming. I hope you learned a lot. And thank you all for sort of being involved with the Memory and Aging Center in general. And then also to please fill out your evaluations and to maybe move them to the center of the table or just bring them forward when you come out. That'd be great. Thank you.